have you. I mean it. Your work has been very influential, and we talk about you a lot in our
Yay.
classes and in our office hours. And I would love just to have you share, because we have new students that come in all the time. And we do have a student provider clinician here who's such an advocate of the work you do. And he has been really, it's Matthew Bereen. And I really appreciate how much he has connected the dots inside of myofunctional therapy cases and when things don't go as planned, and really trying to see if we could look at that element, meaning the vitamin D element. So I am just so happy you're here. I would love to, I'm going to introduce you officially so everyone knows who you are in case they don't. Dr. Gominak attended Baylor College of Medicine in Houston, receiving your medical degree in 1983, completed a neurology residency in 1989 at the Harvard-affiliated Massachusetts General Hospital in Boston. And from 1991 to 2004, she practiced as a general neurologist in the San Francisco Bay Area. And she has since, in 2016, she moved with her husband to Tyler, Texas, and began to concentrate on treating neurologic illness by improving sleep. She published a pivotal article in 2012 proposing that the global struggle with worsening sleep was linked to reduced sun exposure. In 2016, she followed with the second article linking the change of the intestinal microbiome to the epidemic of poor sleep, and described a simple process for normalizing sleep in the intestinal bacterial population called RightSleep. And in 2016, she retired from neurology practice to have more time to teach. She currently divides her time between helping individuals through virtual coaching programs and sessions, and teaching clinicians and coaches how to use RightSleep concepts to improve their patients' health and well-being. So it's so great to have you. Thank you for being here. And we're thrilled. Yeah.
Okay, well, we haven't discussed whether or not I should jump in and give the full introduction as I have the first time, whether
Yes.
we should take questions. What is it that you're...
So I jump in and go for the presentation, and then time for questions at the end. And we have an hour, so I will moderate, and if there's questions in the chat, people will put them in there, and then we can bring them in at the end.
Okay. Well, my journey began with being a general neurologist. I had half of my practice in daily headache, which is usually a group of young, healthy females, sometimes males, less commonly teenagers, but children also can have daily headache. And one of the frustrations of treating that population is nothing really works for very long. We have medications that work, but they don't last. And one of my patients really demanded a sleep study from me. Keep in mind, this was in 2005 or so. That's, a long time ago now. And at the time, we were not doing sleep studies in young, healthy women. We had made up the idea that sleep apnea happened in older, overweight males with a fat tongue and a fat neck. But it turns out that that's a little too simplistic. So this particular gal demanded a sleep study because she said her husband told her that she snored like a train and she didn't feel good when she would wake up in the morning. And she had sleep apnea. And that in and of itself is a little surprising because she was not overweight. She was otherwise young and healthy. But the thing that was shocking was that the CPAP device made her headaches go away. And I'd been working with her for long enough to have tried several medications that hadn't worked. And she'd had daily headache for several years. So she wore this CPAP device, which I picture as a torture device. You strap it on your head. If you have daily headache, most of the women with this can't really comfortably brush their hair or put on a hair tie because their scalp hurts. So I couldn't picture how this would have placebo effect. Who would want to do that? And it lasted. So her headaches went away, which to me was shocking. She also did not have any drops in oxygen on her sleep study. The pulmonologist had handed us the explanation that the medical illnesses that came with sleep apnea, and especially at the time, hypertension, diabetes, heart disease, were caused because there were drops in oxygen. Well, she didn't have any drops in oxygen. She did stop breathing, but her oxygen never went down. And I think that just points out that we make up explanations within what we know. We all do that. All humans make up legends, stories, and we want to tell each other those stories. Medicine is no different. So her headaches got better, and I started to do a bunch of sleep studies on young, healthy females with daily headache. And to shorten this a little bit so we have time for discussion, ultimately, it turned out that most of them did not have sleep apnea. But the readers of the sleep studies, the pulmonologists who are reading the sleep study, were not in the habit, and are only occasionally in the habit now, of putting on the front page, on the report page, the fact that they did not have REM sleep, they did not have rapid eye movement sleep, they had shortened rapid eye movement sleep, their rapid eye movement sleep was delayed, they had REM-related apnea. And that was something that finally my pulmonologist mentioned to me, but that was a year and a half into it, after I was very confused, because you can't really give a CPAP device to someone who doesn't stop breathing. It doesn't make sense. So by then I was using a lot of sleeping pills, and it was quite obvious that if you got to sleep better, the headaches got better. And I also realized that many of the medicines that we'd been using for daily preventatives for people with headaches were really helping the sleep. Then the next question was, why would they stop breathing only in REM? So REM-related apnea was something that I had never heard of, and that still happens. But the thing that was most important about it was the pulmonologist then turned me on to the idea that we get paralyzed while we're sleeping, which was really freaky. So we get the most paralyzed of all in REM sleep. And it turns out that we paralyze the whole oral pharynx in REM sleep. Well, that idea really changed my whole view. I thought, no, wait, this is really creepy. How can we get paralyzed? Why don't I know that? This means that even if you have a normal airway, if the paralysis process is not correct, you can paralyze your airway too much. And where is this happening? So that led me to the articles about where we get paralyzed. What's the anatomy of that? And that is really well known from the beginning of the study of sleep, and only in the 1960s. The study of sleep is relatively recent. The first lab opened in Stanford in 1970, but there were videos that you can still find on YouTube that show if you lesion or hurt the cells in the brain stem, the lower part of the brain that becomes the spinal cord, if you hurt the cells that we know are responsible for paralysis, you can see these cats walking around hunting in the midst of a dream. So the little electrodes that are on their skull show that they are in rapid eye movement sleep, but they're walking around. So they're acting out their dreams. That in and of itself was strange and mysterious, but also sort of shed some light on a couple of things. The other thing that was commonly being reported on these sleep studies were what are called periodic limb movements of sleep. And the reason why they're reported is they're not supposed to be there. They are walking movements, actually, of the legs, and they're periodic, which means they come at a regular rhythm. That means there's a center in that same area of the brainstem that is supposed to be suppressed while we are sleeping. And that's kind of interesting. Like, why does our body get paralyzed? It prompts you to ask the question, are the moving parts being paralyzed so that I can repair them? And that's my belief. And because my patients are coming in saying, I have a daily headache and I have knee pain, I have ankle pain, I have hip pain, and they're 29 years old, and in my view, they really shouldn't have those pains, I didn't have those pains when I was 30. So I began to wonder whether or not then, is there a malfunction in this part of the brain stem, which is really my responsibility? This is not the pulmonologist's responsibility. This is not the sleep dentist's responsibility. The anatomy of what we breathe through has multiple different subspecialties, but the neurology of it is happening in the brainstem. That means we neurologists are responsible for this. And if the cells that paralyze us are able to do it perfectly, meaning they find a way so that I keep my mouth closed, I breathe through my nose, I paralyze my airway so that my tongue and all the pharyngeal tissues can repair, but I don't stop breathing and I swallow on a regular rate. That's a complex thing. If it can do that perfectly, it means that if it screws up, then my airway gets too paralyzed. And on the other side, if it doesn't get paralyzed enough, maybe that's what these walking movements are about. And when I ask for a CPAP device for someone, it does not really help the fact that their hips are hurting. So their headaches have gotten a little bit better, but we really have to address the fact that there's extra movement below the neck as well. And since this area paralyzes us perfectly, both of those could actually be answered and helped if we could figure out why this particular set of cells is misbehaving. So that started me on a different viewpoint. And then I was reading a lot about how cells fire regularly, because no one was writing anything about sleep and headache. No one was writing about these young, healthy females that all had abnormal sleep studies. No one was talking about REM-related apnea. I'm reading all the articles and there aren't any. So I'm kind of alone. I'm with my patients. We're on a journey together, and it's very frustrating because they are very uncomfortable. This is not, hey, I would like to have a facial. This is really limiting their life. And I have been unsuccessful for the prior 20 years in getting anything to really last. So it's really important. So we try things, and most women with daily headache will try almost anything. So we try CPAP and we try sleeping pills. And the other thing that was really dramatic about it is everybody wants a different sleeping pill. We have been fully trained never to use them. But in actual fact, there are 25, 30 medicines that can be called sleeping pills. The weird thing is that every single person has their own pill that they prefer. Well, what is that about? If these are sleeping pills, to me, as a neurologist, that means this drug is mimicking this particular neurotransmitter. And this person is low in this neurotransmitter, but these other 5, they're low in other ones. That's kind of mind-boggling too. Why would they have 4 or 5 neurotransmitters that aren't right? Because these drugs are just copying, they're just mimicking another chemical. If I get lucky, it's the right one for that person's brain and they sleep better. So I'm looking at this through a very chemical, biochemical lens. And I'm also starting to look at these cells and think about, well, how would they get wobbly? Because they would be firing perfectly if we were all sleeping normally. But what if they wobbled a little bit, like too paralyzed, and then wobbled towards not paralyzed enough? And what's that about in neurology? So that's really about firing rate. That's the speed at which this nerve is sending messages. So I'm giving you this to let you know that I'm thinking about it in a totally different way. Nobody thinks about sleep as a single cell in the brainstem. That's just weird. But that's where my brain was at the time. And I'm doing this over about 5 years now. So in 2009, this young 18-year-old beautiful gal walks in. She has daily headache. She's about to go to college. I give her medicines for it. She comes back. She's had a sleep study because I do sleep studies in everyone now. And her sleep study is just terrible. And when I asked, she says, my sleep is fine. She sleeps for 10 hours a day or 10 hours a night. But she never gets into any form of deep sleep. So she has 10 solid hours recorded. She has 35 times an hour where she tries to get into deep sleep, but she comes back to lighter sleep. And based on now 5 years of talking to people about how they feel in the morning and looking at their sleep studies, if you don't get into deep sleep, you can sleep forever. It doesn't matter. You don't get into deep sleep, you don't repair your body, you don't repair your brain. So there are specific phases of sleep that you must be able to get into and complete whatever tasks there are that we do. We can only imagine what those tasks are by saying when these 300 women don't get into deep sleep, what are their complaints? They can't remember anything. They're in a bad mood. X, Y, and Z hurts, and they have daily headache. Well, that means if you don't get into those phases, you don't really repair your body. So this young woman is 18. She looks perfect. She sleeps 10 hours a day, but she has no deep sleep. And because I didn't know what else to do, she had no apnea, she had no drops in oxygen, she did not have any respiratory related arousals. There's absolutely no explanation on the report, the observation. And now I've learned how to read them, so I know what to look for. And she says, you know, my headaches are much better with the medicine you gave me, but I'm so tired. Is there anything you can do about that? And because I really didn't know anything, I said, okay, well, let's check your thyroid and your B12. And her B12 turned out to be profoundly low. And it's not something I would ever have been interested in because we doctors have been successfully brainwashed against vitamins. But for the first time, I'm thinking about that one cell that's supposed to be in a group paralyzing her body. And I think, you know, what if, I don't even know what B12 does at the time. It's still not that clear to me. But that's a pivotal part of our biochemistry, or that particular cell whose job is to paralyze me perfectly is missing what it needs to do its job. That's a very unique viewpoint. And we give her B12 and her sleep gets better. So then I start to do B12 levels, and all of these people who I've now got about 1,000 sleep studies and people who are seeing me for various things, because now I'm doing sleep studies in epilepsy patients and basically anybody who let me. And I'm really finding out that every single person who comes to see a neurologist has a sleep disorder. If you know what to look for, and you don't just say apnea, no apnea, instead you look at the actual recording, then you'll find that everybody who's seeing a neurologist has a sleep disorder. And some of the people who put CPAP on have these miraculous things happen to them. Their hypertension gets better. They're now on one medicine instead of 3. Their diabetes gets better. They come off their oral hypoglycemics. There are so many things that get better when they put on this torture device that, to me, it makes this very loud message. Sleep is how we stay healthy, how we don't acquire these diseases. Yes, there is a genetic basis for them, but if there's a genetic basis, migraine is completely a genetic disorder. No question about it. We have all these genes. We've clarified that. But I didn't start to have those headaches until after my 3rd kid. What's the second variable? So what we're calling epigenetic factors. Sleep, obviously. We repair our body every single night. And for reasons that were confusing to me, we in medicine have studied sleep last. It's like, oh, well, really, we only started studying sleep when a huge part of the population became unable to sleep. And really, when you think about medicine a little bit more, that is the way medicine is designed. We do not gather 20 patients who have never seen a doctor, but have no medical problems and are now 80 years old and carefully study them. The people who are healthy don't go to the doctor. The only thing we have gotten over historically in medicine is when something falls apart, we come in and we try to fix it. And sometimes it's kind of crazy, like a CPAP mask. And now, in the last 50 years, we moved towards pharmaceuticals so dramatically that we're really focused on, let's find a medicine that we can make money on. All of us who are listening to this, and I who is speaking, we want not to go to the doctor. There's a big conflict there. That means we really should be thinking about, how do I maintain this amazing miracle of self-healing every single night. So that's what starts this. B12 opens the door to maybe the brain could be missing something. And then B12 turns out to be low in some people and not in all. Because of something one of my patients said to me, I started to measure D as well. I knew nothing about it, completely naive. And so for 4 months in 2009, I measured D levels and B12 levels. So this is the patient is serving as their own control, really. And I'm not a scientist. I have no interest in designing a study. I just started to do D levels. And one of the big important points we're going to make later is the D levels that were being done in 2009 are hormone levels, because it's a hormone. And every single hormone that we test in medicine goes into a big machine that does what's called liquid chromatography mass spectroscopy. And the reason why it's used is these hormones have very specific physical characteristics. So you have to do very specific testing to know the difference between progesterone and estrogen. They look real similar. One's made from the other. Testosterone looks real similar. D actually looks really similar. D is made from cholesterol. Testosterone is made from cholesterol. So is estrogen. That means you need this big special machine to get exact testing. Now, I knew none of this at the time, but I'm testing D levels, and it turns out that between August and December of 2009, everybody's D is low. But I know nothing about it, nor do I really care. I'm just sending out lab slips every night saying your D is low. B12 wasn't as big as I thought it was going to be, but the people who did get B12 shots would come back to me and say, you know, I get that shot, and for 2 nights I sleep great, and then I have 3 terrible nights, and then I get my shot again. And they're giving their own shots, and they're giving those shots every 5 days. So B12 is proof of concept. This is something the brain is missing, and it affects the sleep. And the most important part is that humans can tell you. Humans can talk. They can tell you what their sleep is like. So that may sound weird, but medicine is about, oh, gee, we have to do a sleep study. Why don't you ask them how they feel? Why don't you ask them what their night is like? So the next step is to say, okay, well, the D is low, but 2 guys come in December, so at the end of those 4 months, and say, hey, you know, I've been wearing the CPAP mask for a whole year, and my sleep definitely got better, but my headaches didn't go away. But then you sent me that note about the D, and I went out and bought, and it was only 1,000 IUs of D. I went out and bought that, and in about 3 weeks, my sleep got better, and my headaches went away. 2 guys tell me exactly the same thing. Now, they're both wearing CPAP. They both turned out to have D levels that were slightly higher. And because that was such a direct link, and because I have nowhere else to go, nobody's got any answers for us, I go to the literature, and the literature shows those cells I told you about that are in the back of the brainstem, this specific nucleus called the nucleus reticularis pontus oralis caudalis, like this totally obscure part of the brain, has articles from the 1980s showing that there are vitamin D receptors in them. That means there is a scientific basis for thinking about D as not a bone vitamin. That is a totally corrupted, really dangerous idea set that has been fought against for more than 100 years unsuccessfully. It is still being touted as a bone vitamin. It is not a vitamin, it is a hormone. We make it. It really doesn't come from food. It was not designed to come from food. If you happen to be an Eskimo and you live in the far north where you have dark skin and you don't really get a lot of sun, then you must, in order to survive there, eat raw blubber and eat raw liver. Otherwise, you are not going to get D. So, 1, there are these misconceptions within medicine that make this very difficult conversation. 2, as I start to learn more about D, and it takes about 2 or 3 years to actually learn how to dose D, because it is a hormone. I'm not an endocrinologist. I'm not used to treating thyroid disease or using estrogen. And you really have to know what you're doing in order to get the D level into a safe place. So the next question was, and I happened to call the guy who wrote these articles. So Walter Stumpf has spent 30 years studying the basic science of where are the D receptors and what does that mean. And he has a beautiful perception of what D is about. It is a hibernation hormone. It allows animals and plants to change what they do based on the seasons. Just like trees, we become dormant in the winter. You can imagine what would happen if we began to gain weight for the winter and we suppressed our ability to get pregnant, so our babies wouldn't be born when there is no food, because there's no food in the winter, because D comes from the sun. If there's no sun, there's no food. So this is a process of allowing us to sleep more, lower our metabolic rate, gain weight so we can have fat to live off, and suppress fertility. All of those things were described by Walter Stump in the 80s, in the early and mid 80s, before the epidemics of obesity, infertility, sleep disorders, etc., were described, because they were starting, and many of the things that we're treating all the time now only became reported in the mid 80s when sunscreen, air conditioning, and computers started. So Walter has a beautiful view of this, and I enter into that literature with that view instead of the bone vitamin view. In a lot of my lectures, I give you a big history of what's happened in medicine about the writing about D and rickets. And actually, D deficiency was well described 300 years ago. 100 years ago, it's described as a cranky toddler who has colic. And it's a disorder of infancy and toddlers who don't sleep, are in pain, are crying all the time, and ultimately they really have D deficiency, but they treated them by putting them out in the sun. And they showed that sun exposure made those toddlers better. Those articles are 100 years old, but they are now forgotten, which is a pity. So then, this is the population that you guys see, cranky toddlers, okay? And I was asked whether or not I can make some connections between the anatomic things that you guys see and D. And at the moment, I can't, but we can fantasize about that. We can make up legends about the possibilities. So there's an anatomic correlate that you guys are asked to face that has to do with nasal breathing and that sort of stuff that you guys are well versed in. So what happens next is I spent 2 years giving D, but the important part that I want you to listen to here is at the end of 2 years, everybody's better. We determined that 60 to 80 is the right range for the D level for a person who has a sleep disorder. That's really important, because 60 to 80 is right in the middle. If most of the labs say 30 to 100 is normal, because there has never been a study that has established what a healthy D level is. Every quote unquote expert, and I don't think there are any, including me, because we know so little about something that is so pivotal for our body. Each expert just says, oh, take this dose. Well, that's completely wrong. You can never recommend a dose to a person. You can recommend they start at a dose and acquire their own information, which are D levels, because the level is really a reflection of what's around in the blood. The stuff that's in the blood is not doing anything except sluicing around. So what happens when we take a dose is we take it in, it gets absorbed, it goes in the bloodstream, and every cell that needs it goes, wait, oh, I really needed this. And it sucks it up. That means the stuff that's in the blood is the leftovers. So at the beginning, it was really shocking that there were some people who had D levels that were undetectable, or 2 or 5. And the first mistake was giving D2. D2 is a prescription, therefore it should be better. Well, it's not. It is from fungus. It is evolutionarily older. It is not what we make. Therefore, if we have what we really make, we should be using that. And in fact, my patients came back and said, hey, that prescription stuff that you gave me made me so much worse. So there's some aspects to how medicine uses D that are historically based and incorrect, grossly incorrect. That means public's ability to be able to get their own D and learn this is why we're having this conversation. If medicine actually took their responsibility in the 80s or even in the 40s and did this correctly, the public wouldn't be responsible for it. So in the background, I get really good with getting D levels. We established that 60 to 80 is the right range. We get better, but then we all get worse again. And this is the important part. We all get worse again, even though my D level is 65. And I start after 2 years having worse sleep again. My butt hurts, which is really weird. I can't sit down at the end of the day. Remember that I was talking about movement during sleep or lack of correct paralysis. So I'm beginning to look at it as, you know, if those little cells can paralyze us, they can turn those muscles back on. That means I could actually be recruiting muscles like my hamstrings, and I could be doing something like that's not so weird, like being in a fetal position and activating my hamstrings, and my insertion site of that hamstring might hurt because it's constantly being stressed while I'm unconscious. That means there's a whole 8 or 10 hours where things are happening to my body that I can't tell the doctor about. I don't know what's happening. I'm unconscious. So that's the idea set. And then we all get worse. And my patients start to come in and say, okay, don't even ask me. My D level is 65, but I'll tell you what, my joints ache. My doctor's sending me to a rheumatologist. I have burning in my hands and feet. My patients start to come back with things that they have never had before. And I'm doing something really out there. I'm giving them D, I'm getting their D into a certain range. And it's 2 years of D, and then these complaints come. That is very creepy because that is not a direct effect. That means there's some delay and something else has gone low. Because a couple of patients came in with this burning in the hands and feet, which I'd already experienced as a neurologist. I am a neuropathy expert. That's what I've been doing for 30 years. So in my practice, they would send me people who have burning in their feet, burning in other places. Burning in the mouth is a really important thing in your area. And we really didn't know jack about it. We would give Lyrica and gabapentin, and I had had B12 actually help people a couple of times. But I had probably only seen 2 people in my practice over 20 years who'd had burning in the hands and feet coming on at the same time. And these 2 women came in within a month of each other. That there's something there that's time locked, and it's locked to the fact that the only thing they have in common is they're seeing me and they're taking D. So with that, I'm completely lost and floundering, and a patient brings me a book that's about, God forbid, another vitamin that happens to be pantothenic acid. And that starts on a whole nother journey. Pantothenic acid is a B vitamin. It's been completely overlooked. It's B5 because someone, and I don't have any the literature of who started this, back in the 50s, they started to study pantothenic acid because they found out that pantothenic acid was necessary to make cortisol. When they made that connection, then they actually started to use pantothenic acid in experimental studies to prevent or treat rheumatoid arthritis, lupus, all the autoimmune diseases. Because around the 50s, we've come up with prednisone, and we realized that there's an anti-inflammatory. It's the very beginning of understanding inflammation. So pantothenic acid is needed to make cortisol, and there were clinical trials in the 60s, 70s. And then in the 80s, somebody said pantothenic acid deficiency doesn't exist because it's in every food. And that's what all the literature says now. Well, I actually received this book from this crazy patient who had a lot of things wrong with her. And this book was about giving pantothenic acid to people with rheumatoid arthritis. And the reason why she brought that to me was, it says their joint pain gets better and their sleep gets better. So this turns out to be another pivotal B vitamin that plays an important role in sleep. So I run to the vitamin store because I'm desperate and I don't know what else to do. So we've undermined my fear and loathing of vitamins at this point because my butt hurts and my patients are getting worse. So I go and buy 400 milligrams of B5, which is what's sitting on the shelf, but I also pick up a B complex. And at this point, there's a wrong turn where it turns out that my patients needed much lower doses than the patients in the book. And then I have to put together all this material. So ultimately, not only did my patients get worse because of what I did with D, and that is what is happening right now. Everybody who started on D during COVID is now 2 to 3 to 4 years out from starting D. If you start D, and even if you take small doses, what will happen is your body is happy. It's making repairs. D is a trophic, meaning growth producing hormone that affects hundreds of parts of our body. If it starts to make repairs and your sleep gets a little bit better, what you are doing is making repairs with that time and sleep. You're not just unconscious. Those repairs, they are built on B vitamins and all the other components that are in a multivitamin, all the minerals, all the cofactors, everything each cell needs. It is trying to repair itself. That's thrilling. That's what we want. But all the basic factors that it needs to do that, it turns out most of them are missing. They're too low. What happened there was we ran out of our stores of B5. So as we increase the rate of repair, we use up our B stores. And in actual fact, what we've been told about the B vitamins is mostly wrong. The idea that we pee out the excess, the fact that we don't have stores, they're water soluble, all that stuff is made up and is incorrect. There are good scientific articles supporting the idea that we have stores of vitamin C, of the B vitamins, probably of B12 as well. That means our level of understanding of these basic pieces of our metabolism and our citric acid cycle and what our mitochondria are doing has been suppressed when medicine said vitamins aren't important. If you have a good diet, you don't need vitamins. And maybe that was true in the early 80s. The most pivotal finding throughout this time, so now I'm giving B vitamins, and it turns out that B5 is extremely powerful in sleep. And if you take the wrong dose, you won't sleep at all. And that's what happened to the majority of my patients. I gave them 400 milligrams because that's what it said in the book. And they came back and they said, this stuff here, were you trying to kill me? I felt so awful. I was all revved up and tense and anxious. And they would often use the same words. You know, these are people that don't know each other. The only thing they share in common is I gave them 400 milligrams because that's what the book said. I took it myself. And I was also taking a B complex. That's a large dose B complex. And my restless legs got much worse immediately. So that means, one, my patient group is different in some way than the people in the book. What's different? They're all taking D. That means there's a synergistic effect somehow. I knew nothing about what was causing this, but when people come in and say, I couldn't sleep at all for 2 nights, and then I stopped this, and it's the 5th patient in that month who's told you that, something true is happening in the background. So even though pantothenic acid deficiency supposedly doesn't exist, some of those patients and I stopped the 400 milligrams of B5. We stayed on this thing called B100 and immediately felt better. On B100, my butt pain went away. Boom, like in a day. That was really weird. So a lot of the people who'd had inflammatory arthritis type pain, generalized arthritis, would come back and say, well, this stuff was terrible, but when I stopped it, this stuff, this B100, I didn't have any pain. In 2 days, my pain went away. Now that is really weird. You know, I've been a doctor for 20 years. No one's going to believe me. I'm not going to tell anybody about it because it's too weird. So ultimately, what I've done over the last 10 years or so is to try to piece together the science. So in the background, what is happening here is that D makes an enzyme called choline acetyltransferase that makes acetylcholine. And B5 is the backbone of another thing that we need in our cells called coenzyme A. And when you go B5 deficient, you do not have coenzyme A production normally. And in order to make acetylcholine, you must have choline and acetyl-CoA. They come together with the enzyme that the D is making, and then you make acetylcholine. And it turns out that the great majority of the chronic illnesses that we're treating now are related to acetylcholine deficiency. And that is not something that would ever made any sense to me 10 years ago, because the whole concept that you become deficient in a neurotransmitter is completely crazy. How could we even operate under those circumstances? Here is the core of how that happens. D must be present for your bacteria to be the right group. So the other thing that happened in the middle 80s is the microbiome started to change. The great majority of the people teaching about this say that it was the antibiotics, but I know it's not. the antibiotics. Why? Because I existed before. During 1945 to 1985, there are 2 full generations who were using antibiotics all the time, and we did not have IBS. IBS started to be described in the 80s. That means we use antibiotics. Also, the first makers of antibiotics are the bugs. We took penicillin from a fungus. We saw this little fungus growing there and it had this clear zone around it. And somebody said, hey, I wonder if this guy's making like a chemical that kills its competition. Yes. That means we now have lots of literature that suggests that the viruses that live inside and on us, like a little cloud covering us, make antiviral chemicals that protect us. They are trying to compete against other viruses. They aren't doing it for us per se, but we exist as our own little independent ecology. And that means fungus, virus, bacteria are making antibiotic, which means anti-life chemicals. They have always lived inside us. They are evolutionarily way older than we are. And in fact, bacteria are the first living organisms. And they make chemicals that dissolve the stone that they're sitting on and are actually able to separate out iron and nickel and copper and zinc and start to incorporate those little charged ions into living biologic patterns. That means if we don't have the right ones, we are really not normal humans. So if you look back and say, when did IBS begin as a signal of when was a global change in our microbiome contents, it was when the D started to go low. And it wasn't until 2020 that the first articles recognized that, and it was during COVID, not by chance. It was the first article that said, what if we move the D dose? What happens to the bacteria in our patient's belly? And they measured that pro-inflammatory bacteria were suppressed and healthy bacteria grew when you gave a bigger D dose. So because D has been minimized, the connection between you must have a D over 40 in order to have a normal microbiome was missed. That means the most important part of this lecture is you must bring back the normal microbiome in order to fix our patients. Now, your patient group is slightly different in that they have anatomic issues as well. And I really cannot make that connection completely between tongue tie, etc. So, but I want to back up and say, the thing that you should be focusing on is not just a D level. You have to have a D level done by a specific technique. And over the last, unfortunately, since I did this original stuff in 2009, because the doctors started to do more and more D levels, the laboratories, and it cost them a lot to shoot those samples through that big expensive machine, the laboratories started to devise what are called immunoassays that are exactly like the COVID tests we did. They are very inaccurate. They use a completely different technique. We have now at least 30 articles that show immunoassays are not as accurate as the LCMS technique, especially in the higher ranges. So if your D level is 30, it's likely that those two types of tests will be quite similar. But as soon as your D level gets up into a place where you're better, they do not have the same accuracy there. So for instance, you might get a D level done by the LCMS technique and it's 59. And then you do one in your doctor's office and it's an immunoassay and it's 79. Well, within my belief system, 59 means we need to go up. 79 means we need to go down. That started to happen in my patients in about the maybe 2011, 12, 13, when I would have other people in my community doing D levels with their primary, and they'd bring back a D level that was 80. And I was like, wait, this does not fit with the other D levels we've done. You haven't changed your dose. And I really began to realize that the other practices would buy a D machine and they were being told by Abbott or Roche that this was actually accurate. It's not. And that's well published, but it's much cheaper for the lab, and the doctors can do this D level. It doesn't cost them $500,000. that practice isn't going to spend that. Instead, they spend $500 and they're giving out these D levels that are inaccurate. The thing that's different about D is when you do an inaccurate thyroid test, your patient says to you, I don't believe that because I feel like shit. So when you say, well, honey, it looks like your D level's fine. This is partially within the context of how physicians treat their patients. We minimize what they observe, and it is partially a male-female issue because the doctors were male, the patients are female, and they minimize what we have to say about our body. That is wrong. So now over time, because the public is more well-informed, the doctor is not going to be allowed to get by with, well, your thyroid looks fine. The patient, she's a female, is now an informed female, and she's going to say, I'm sorry, I don't feel good. I'm going elsewhere. D is exactly the same. You can teach people how to know where their D is it too low or too high, by observing what happens to them and correlating it to D levels. The doctors don't have that information. I do. I have thousands of people who told me what they feel like. And my particular signals are when my D goes to 58, I start to get a visual aura migraine. I start to wake up at 3 a.m. and I can't go back to sleep. A lot of times I get a clear runny nose and I get constipated. When my D goes too high, I start to ache all over. But each individual person has to generate what that is. Because we don't look at it that way in medicine, medicine has let these inaccurate tests just do fine. And it's around the world. We are one of the few countries in the world now where you can personally get your own accurate D level back to you within 3 or 4 days for $39. Most of the countries in the world have gone over to using immunoassays. So in the background, this is a little difficult if you're outside the US, but once you get good with your D level, there is a second piece. If you do not do this second piece, you will have bad things happen to you. Each one of us has our own genetic tendencies or our own genetic weaknesses, and we will manifest in whatever that genetic tendency is. But ultimately, if you do not correct the microbiome, and correcting the microbiome is not about probiotics. Correcting the microbiome is about taking D, which is a growth factor for the bugs, and combining that with B50, which is a large dose B complex. The reason why there are 8 Bs, if you've never thought about it, it took me like 5 or 6 years before this ever occurred to me. Why is there A and then 8 Bs? Like, what's up with that? They are all 8 coming from the microbiome. That means they are intertwined. So one of the things you'll read about the bees is when you give one bee, you should give all of them. To bring back the microbiome, you must give them the growth factors that they used to be getting from their buddies because they grow together as 4 basic phyla in your belly. So you give D plus B50, you give a multivitamin. Keep in mind that all of the minerals that we've used to be cofactors for all of these biochemical pathways are also low. The reason, in the last 3 years, there are remarkable publications that document there are certain bacteria that must be in your belly that secrete a metabolite. Something we haven't called a vitamin yet, but it's a chemical that bacteria makes that we can't make, that is absorbed into our body and becomes part of the pathway of the brain being able to tell the intestine that we need to absorb iron. So one of the things that's also become common is iron overload and iron deficiency are both much higher incidence in the last 40 years than they were before. That means most of us don't have iron as the cofactor to make the neurotransmitters like serotonin, dopamine, norepinephrine, epinephrine. So we are deficient in multiple neurotransmitters that are related to inflammation, sympathetic overdrive, and sleep. So in the background, to put this all together, we have not only acetylcholine deficiency because of D and microbiome deficiency, but we also have multiple other cofactors that have to be addressed. Also, we need to be careful of the idea that when we biohack with these chemicals in doses that are not available, we are doing something that is unnatural. What is the final message? Go outside. Put the children outside. Use sunscreen when it's appropriate. When we go outdoors, we are actually exposing our body to multiple wavelengths of energy, some visible, some not, that interact with our biology. This will be the next wave of how do we get healthy. But ultimately, we have suffered because we have been told that it is bad for our children to be indoors. Being outside is the way we evolved with every other animal, and it has really undermined our health. And I'll stop there and ask if there are any questions.
Wow, that was fabulous. And a lot of layers to unpack. I know that you talked about B complex, B50, B12, B5. So when you're making these recommendations and how to test, we did have somebody kind of put in the LCMS testing protocol, how to get that. Do you give B12 or do you give B50 or B complex, or how do you elevate those B levels?
This is why I have a workbook. Okay.
Yeah.
Every single person who hears this lecture goes, whoa, this is way too complicated. Why don't you just tell me what to do? And I think that's a perfectly reasonable response. But you actually have to be included. The person doing this has to be able to notice, I did this and this is how I feel. So the reason why I'm telling you about this relationship between the doctor and the patient is that's not the way we practice medicine. I'm the one with the lab result and I tell you what to do. That's not the way it works. You must actually train yourself. So I have a workbook that tells you what to do. I have a whole website that gives you all of this in great detail, the science behind it. You can get at the articles that I wrote with Walter. You can get at other articles. I'm going to put up a section with references as well, but you need to learn a little bit more. It's not as simple. What we've been told is, oh, you just take vitamins. It's not important and it doesn't hurt you. That's not true. You really do have, if you want to fix yourself by getting your sleep better or advise your patients or guide your patients to do that, there are some pretty specific things that you have to do. And it's way too many letters and numbers. I completely agree. So I can give you a general brief discussion of that, which is what I've done. So if your B12 is low, you need B12, and I give you very specific doses to try. The reason why I encourage people to go back to my website and actually buy the program. The program includes a workbook that tells you exactly, step by step, exactly what to do, what you need to know, when you need to do your D levels, how to get them done. And the second half is it encourages you to journal how you feel, to focus on what's wrong, what gets better and what gets worse when you take these vitamins, how it relates to your D level, how it relates to the Bs, so that you can actually learn how to listen to your body in response to what you're taking. But also, along with that program, you get videos that are about how to do this in children of specific ages. This is very important for your practice. How to do this when you want to get pregnant and you have been infertile, which is what recently happened with my daughter, who now has a beautiful daughter, Eleanor, our grandbaby. So she had to go through infertility, and the infertility specialists know that these articles exist, but they have not followed this path. They're just starting to. So there's plenty of confirmation that infertility is all about D and the microbiome. So I have videos that are specifically about infertility during pregnancy and during the first year with your baby when you're breastfeeding, how to understand what we're doing with these vitamins within the context of, in the past, the baby is developing using the B vitamins that are coming from the mother's microbiome. Well, if the mother has been D deficient for the last 20 years because she's following what medicine has told her and she doesn't have the right microbiome, that child is not developing normally. Thus, the connection to autism, which is increasing epidemically over the last 40 years. So this is a complex set of knowledge, but it's also extremely powerful. So when you buy into the program, you get the workbook, you get a Facebook group that will help you with other people who are actually doing this themselves. And you get access to 2 years of Q&As where you get a lot more detail, and you can take it in little bits when you feel like you're ready for it and focus on which parts of it are important to you.
Matthew, you have been such an advocate for this, and I know you have brought a lot of the information. He's a student of yours as well.
Thank you, Matthew.
And I was wondering, Matthew, he talks a lot about the calibration and the complexity, but that's why it is so important to have the information that's step by step in the program, and the Q&A Facebook lives and the replays of you answering questions on a monthly basis. I get them in my inbox, and it's really helpful. And it's incredibly complex, as you said. Quickly, D3 and K2 usually have been, do you have any thoughts about
K2 is not involved with D's absorption. People get really sloppy with, let me just preface all of this with saying, I don't know everything, okay? I know what I know, and sometimes I change my mind when somebody gives me a good article, and I'm very willing to talk about that. I'm learning as you guys are learning. But D's absorption has nothing to do with K2. K2 has a very specific, K2 is also a hormone. K2 is also made by our microbiome, and it appears it also comes from food. K2 directs the calcium that is increased. So D's job at the bowel that has to do with bone. Okay, and this is a tiny little wedge of what D does throughout the body. But one of D's actions is it increases the amount of calcium that we absorb. That means once we have more calcium, the K2 is involved in directing that calcium to go to the bone and not into things that shouldn't be calcified. So there are two situations where I recommend K2. If you've been told you have osteopenia or osteoporosis, or if you've had studies that show that you have things calcified, like your coronary vessels, that shouldn't be calcified. But in a general sense, K2 usually comes in the multivitamin, and I'm already recommending like 4 to 6 pills for people. For most of us, like, I don't want to take anything, I want to be healthy and not. So I did not add every single thing in the program that I designed. I have the bare minimum. There's a whole hour about magnesium if you want to talk about that. There's 3 hours about iron. There are many other things that I have fallen into over time that have been extremely important in sleep. And we talk about those in the Q&As because there are many metabolites that are playing a role in sleep. But the general simplified program that works for most people is delineated in the workbook. I was going to add one other thing, and that is, I really think it's important that those who are really interested in introducing patients to this have to understand the concept that the patient really needs to learn how to adjust their D levels, because when they leave your practice, they're still living this. They're still going outside. If they're still taking supplements, their D levels can go too high. That means this is a really different undertaking than what you've done with exercises, etc., where bad things can happen to them if they don't take the time to learn how to use these vitamins safely. That's a big step. Where the hardest part of this for me is trying to convince people that they really need to learn how to do this on their own.
Mm-hmm. Do you ever find any symptomology around related to low vitamin B and tinnitus, vertigo? What have you found?
Tinnitus and vertigo are just another phase of migraine. They're coming out of the brainstem. I have another lecture that you have access to with these videos that is completely about the primary neuroanatomy of migraine, why it happens, why it's relapsing, why sometimes people can have, and the genetics of this is well worked out now. So if you have a certain genetic mutation, your family can actually have migraine with paralysis on one side. Because that's so dramatic, You know, if you just went and asked everybody who has headache is extremely common. So one, it turned out that migraine during the reproductive years frequently becomes vertigo after menopause. That means with another little hormonal change, it's the same event, but it's happening in a slightly different area of the brainstem. Tinnitus is about turning on the hearing apparatus in the brainstem. It's about making white noise. That's analogous to turning on the head pain system inappropriately. Vertigo is turning on the system that would perceive us spinning in a chair, but we're really not spinning in a chair. It's producing that sensation at the brainstem level. These are kind of complex neurologic concepts. I'm not the only one talking about them. There's a minority opinion that knows that migraine is a brainstem issue. And that brainstem issue is because these other nuclei that have other responsibilities are right next to the stripe that does sleep.
Bella, you had a question and then we have to wrap it up. Do you want to go ahead, Bella?
Hi, Dr. Gominak. Thank
Hi,
you so
Bella.
much for another brilliant talk. So my question is, one really smart nutritionist once told me that you cannot take more than maybe 4,000 units of vitamin D, because when we take more, and at the time when it is in the blood, when it is still not absorbed, it gives the body the signal that, okay, it's too much D, and that D needs calcium to get absorbed. So the calcium gets out of the bones, and this way, if we take too much D, we could create osteoporosis because the calcium would be pulled out, because the normal D should come from the sun, not from the food, and not from what. So what do you say about that?
That's going to take a long explanation, but that is a misunderstanding of the interaction there. So the parathyroid is the organ that's responsible for adjusting our calcium level minute to minute in our blood, so that each cell can have enough calcium to go on and off. It's a major part. And so the parathyroid takes it when there isn't enough circulating, it takes it out of where we store it, and that's in the bone. Osteoporosis is caused by a low D, not by supplementing D. And you know that because over the last 50 years, instead of giving D, the pharmaceutical industry has made 6, 7, 8, 10 drugs for osteoporosis. Instead of saying, you know, we should do a prospective study. Gee, let me give you an idea of what that would be like. There is currently no study that documents what D level you would have to maintain in a population of, let's say, 10,000 women, because it affects women more because we have the babies. What D level would I have to maintain in order to prevent osteoporosis? So we would have to collect that group at age 40 before there's a big incidence, make sure that none of them have osteoporosis. Then we would have to give them a D dose and then follow their D levels at least 4 times a year and say, we're going to maintain this 50 people, these 50 women, in a level of 20 to 30 for the rest of their life. We're going to maintain this 50, 30 to 40. This 50, 40 to 50. This is how thyroid studies are done. This is how all other hormone studies are done. If you don't know what the right level, and every hormone is a homeostatically maintained chemical that has many effects. You have to then break them into quintiles, where it's 20 to 30, 30 to 40, 40 to 50, 50 to 60. I just told you how complicated this is, okay? Out of those 5,000 women, you would have to follow them for another 30 years until they're 70. And then you'd find out that the 20 to 30s have osteoporosis. This study has never been done. That means we've known since the actually since the 20s, when we started to say, look, these kids have funny looking bones, not all of them, but some of them. The bone action has been the center of attention, yet there has never been a prospective study that has established this is how we could prevent osteoporosis in our populations by doing this in an intelligent way. There are other authors writing about this for the last 30 years. Instead, they say, well, let's just give Fosmax, because the actual dose or recommendation to go outside, if you look into the literature, there are epidemiologic studies that say things like, well, let's try to correlate between people who live outside and their incidence of osteoporosis. So the idea set is there. We have hundreds of articles about when the D is low, there's more likelihood of diabetes. When the D is low, there's an increased risk of blah, blah, blah. There are hundreds of articles between about 1970 and 10 years ago. There are thousands of articles making the connection epidemiologically between D and certain diseases that are chronic and common now, including osteoporosis. But the prospective studies are done with a constant dose. They just give everybody 2,000. And then they don't measure the D levels. They don't even measure them. And they don't even pretend that they're embarrassed about that. They just don't make the connection because it's called vitamin. That should mean this is a public health issue. And I should just have a government that recommends a certain dose, and that's it. So that's a very that's a very complex set of interactions. It's not that that person is not paying attention. She's gotten partial information. He or she has gotten partial information, and she's still really smart, but it's a complex issue.
So in your opinion, what is the maximum daily dosage of D that would be safe?
That is not, you can't answer that question.
Oh.
It's not about the dose, it's about the level. Once you start doing this with patients and following their levels, you will find that that measurement of 32 does not have anything to do with how profoundly deficient the cells are. Because you can have 8 different people who have a level of 32. And in order to go from 32 to 52, one of them needs 2,000 a day for 2 months. The next one needs 10,000 a day. The next one, we're still giving 15,000 a day because her level didn't move. In fact, it went down on 10,000. Her level was 32 also. 32 is a snapshot of what's happening at the moment, but it does not speak to what's happening on the cellular level. And since my interest is in the brain, that level of 32 is not that, it's what we have. It's all we have. But, and it's still confusing because there are all these other forms, and it turns out even the really smart experts in D, if they don't read Andrus Slominski's stuff, they don't know that there are actually 25 active forms of D. There are more than just one D receptor. It is profoundly complex. That means we are jacking around with something that is potentially very dangerous for people. And that's what's going to happen is I just wrote an article about burning mouth. You guys are going to see more of this because that's the area that you see. And because as you take D over 3, 4, 5 years, you use up the B5. Now B5 deficiency is very common. And that's one of the manifestations. There are many.
Well, I really do recommend that people investigate further in the program. It's so fairly priced. It's such a huge resource. I'm really I'm a big believer. I have done it myself and I'm learning about it every day, and it is complex. So I feel that I do feel like this is a very wide gap that we need more focus around, especially in the world of sleep, is what we're dealing with our patients, and even some of these movement disorders or vestibular issues that show up with our patients. So thank you so much for being here. It was really wonderful to hear you speak. Everyone is so appreciative. I'm so happy that you were able to join us, and thank you again.